Okay, friends, good afternoon. In the interest of time, we'll start now, and we hope we'll be joined by others soon. Well, welcome to this session. The title of the session is Financing Strategies for Family Planning. And I have 4 speakers who will be sharing their research, their ideas, their experiences with us. You all know we had so many submissions to ICFP, and these 4 are technically very sound papers, and we would like to hear from them and when they share their experiences. The 4 speakers that are going to present today in this order are, first one is Beatrice, the second one is Richmond, then Umul Kultum, who will be represented by Ula, and the 4th one is Bryant Lee. His paper will be presented by Sunita Sharma. All speakers will have 15 minutes, and I hope you stick to your time so that we can finish in time. There's another session immediately after our session, so we won't be able to go beyond our allocated time. And I also need at least 15 minutes for questions and answers. So without any further ado, let's start with the first presentation. The first presentation is by Beatrice. Beatrice holds a BA honors degree in sociology and geography, and she has worked in a number. She has received trainings in a number of universities. She is currently working as Assistant Director of Population with the National Council for Population Advocacy Portfolio, and is also a family planning focal point at the national level. The presentation is she being the focal point for family planning, and she effectively coordinates commitments for Kenya, where one of the commitments was for family planning, domestic financing. Beatrice, the floor is yours, and you have 15 minutes. Thank you.
Is it on? Can you hear me? Okay. Thank you for the good introductions. Welcome to learn more about how we're doing family planning advocacy in Kenya. In terms of my presentation, I'll give you a little bit of background so that you understand where we came from, what is the intervention that was in place, the methodology, the results, and then we look at the policy lessons that we have learned. Now, in terms of background, we know that Kenya had the first, in sub-Saharan Africa, we had the first family planning program that dates back to 1967. And in this program, we've seen consistently increase in modern contraceptive use to the point where we have seen gains in terms of maternal deaths reducing from 488 maternal deaths per 100,000 live births to the point where we are at 355 maternal deaths per 100,000 in 2019. And child health has also improved greatly. To that effect, we have seen a demographic transition in Kenya. With the last census that was done, increasingly we begin to see a decline in the number of children being born in our population, according to the pyramid. Now, in terms of family planning commodity financing, there was a lot of advocacy in from 2005 in Kenya about the need to have domestic financing and a budget line for family planning. Those efforts managed to reap a lot of gain, such that by the year 2010-11 financial year, we had the government accounting for almost 88% of the family planning commodity needs in Kenya. This continued up to 2012, the financial year 2011-2012, where we now had a change in our government system. We had a new constitution that allowed devolution to be part of our system. Now, with devolution, the health sector was, health services were devolved. And the expectation was that the money would go to the counties to be able to purchase family planning commodities. And this did not happen for 2 executive years. The government did not put any money. And you can see from my presentation that there's actually a very big gap here between the next 3 years where we kind of don't see any government financing, and a lot of it was just by development partners. So it is later in 2016-17 that we got the Global Fund facility, And that allowed us then to be able to start financing, the government to be able to finance. This is a loan from the World Bank, and it allowed us to then, the government to commit some money towards family planning commodity. Now, the other thing that we faced is because of the donors were gradually getting out of financing family planning commodities, we had a memorandum of understanding with our development partners who finance FP commodities, and they agreed on a certain sustainability mechanism where the donor would gradually reduce their support towards family planning, with the hope that initially it was the year 2023, 2024, but later on we were able to negotiate with the development partners to be able to push it to 2025, 26 financial year, where it is expected that the government will be able to fully finance domestic commodity financing. Now, in terms of intervention, working with the civil society organization, there was a lot of push discussing with the community members, because in our current constitution, public participation becomes very important on where the government puts their money. So the people were able to indicate that they needed the government to finance family planning, they needed family planning in our National Health Insurance Fund. And one of the agendas of, we called it the Big Four agenda, also emphasized on universal health coverage that also included family planning. We also had the youth policy being developed at that point in time that acknowledges the International Conference on Population and Development Program for Action, which recognizes reproductive health and rights as a cornerstone for population and development programs. It also emphasized the need to have youth-friendly services in reproductive health, information and service provision, and also to ensure that the young people were able to be targeted during emergencies by providing services like for early pregnancies, HIV, unsafe abortions, and STIs. Now, one of the things we did with the FP 2030 commitments, as has been indicated, we had financing as part of our commitments, and we got the National Treasury to be able to sign on to these commitments because of the financial angle. And in the picture, you're able to see the representative of the, sorry, put it off. The representative of the National Treasury, the chief, we call it Chief Administrative Secretary, signing on to the commitments. That is actually acknowledging and allowing the government to take a lead in that process. We also see the MOU was first of all put in place in 2019, but it's not until 2021 that we are able to see the MOU between the government and our development partners who support family planning in Kenya. That is USAID, we have FCDO, and we also have Bill and Melinda Gates signing onto an MOU that would then allow us to gradually take over the financing of family planning commodities. So here we see our permanent principal secretary with the development partners signing the MOU. Now, we received funding, as the National Council for Population and Development, we received funding from Clinton Health Access Initiative to be able to see how do we then advocate, because as NCPD, the national agency that is in charge of population and development, we advise government on areas that have been left behind. We advocate and even do advisory papers. We carry out research and public education on different issues. So in recognition of that, Clinton Health Access Initiative gave us funding to be able to see how we can carry out that advocacy process to ensure that the funding for family planning was able to come through. And we started this by having a capacity building where we talked about policy communication. How do we then communicate with our policy makers? We developed a policy brief, which we then presented to the Ministry of Health and to NCPD management so that that could be used during the medium-term expenditure framework to be able to advocate for an incremental funding towards the FP commodities. This is just an example of the policy brief that we developed, what we needed to put in place, and why we were justifying a case for family planning. Now, the results is that, as I had indicated, we had 2 years extra to be able to allow us to get to a sustainability mechanism. We were able to scale up the domestic funding, and as agreed that by 2026, the country can be able to fully fund their FP commodities. We've seen through this process, we've seen an increase in the funding from 5.5 million in the financial year 19 to 2020 to 10.2 million in the current financial year. And that is as indicated in the last budget statement that was read, and which actually highlights what the government has committed at the national level towards family planning commodity security. Now, in terms of implications of this, we've seen a lot of development partners and civil society organizations coming on board to be able to support that advocacy, because we all know worldwide, or even in sub-Saharan Africa, it's one thing to commit and it's another to disperse that money and to ensure that it is utilized for the intended purpose. We've also got, through the FP focal point movement, we've been able to agree on how we can be able to monitor the allocations towards what has been committed in the signing of the MOU, and further, because we have this county government system, to also be able to get them to commit some funds that would allow to improve the quality of service. One of the things that we've been able to do is also to develop a digital system that has integrated what is in our Kenya Health Information System with the logistic management system, so that we can be able to see how are we consuming the products that we have to reduce on wastages that have been in place. I want to acknowledge mainly my organization, the National Council for Population and Development, the Ministry of Health, and Chai, just to get us into this space where we can continuously be able to carry out our advocacy activities. Other partners that have come on board include UNFPA, USAID, and the motion tracker in just helping us hold ourselves to account. Thank you very much.
Thank you, Beatrice. You actually saved some time for us, the others. That's what we expect from everyone. Thank you. There's some very important points that you mentioned. I wouldn't be discussing them right away, maybe later on, but some of the points are very important. Let me call upon Richmond to talk about his presentation. Richmond is a PhD in public health and is a health economist at the Ghana School of Public Health. We had a great discussion before the session, Richmond, and his interests include economic evaluation, costing of health interventions, health financing, and health technological assessment. He is a member of the Ghana Health Technical Assessment Group, and a member of the African Center for Disease Control and Prevention. The paper that he's going to present deals with the consumer market for family planning implementation in Uganda, Nigeria, and Kenya. Richmond, the floor is yours. Thank you.
Thank you very much. I'm Richmond Ousu, and I'm presenting to you the economic cost of assessing modern contraceptive in sub-Saharan Africa, specifically in Kenya, Nigeria, and Uganda. About 280 million women in low and middle income countries are said to have unmet need for modern contraceptive. There is wide accepted evidence that modern contraceptive use is cost effective, and if the need and the demand for it are met, it brings about reduced health and economic inequities. But what's the problem? The problem is that financial and economic cost is a barrier to achieving universal coverage for family planning, and this is particularly the case in resource-poor settings. Unfortunately, when it comes to the economic burden that users bear in terms of the costs in assessing modern contraceptive, it is under-researched. And this is why we have to do this study. But more importantly, Elizabeth makes us understand that every $1 spent on contraceptive services beyond the current level would save about $3 in the cost of maternal, newborn, and abortion care, because contraception reduces unintended pregnancies. This study specifically sought to estimate the direct and indirect cost that modern contraceptive users bear in the regions of Nigeria, Kenya, and Uganda, and also assess users of contraceptive, their perception about affordability when it comes to contraceptive products and services. How was this done? The main data, it's coming from the Consumers Market for Family Planning project, which was undertaken by PSI in these 3 countries. And it has streams of studies. They studied family planning outlets, household surveys, among others. And these study sites in each country are not randomly sampled, so they are purposively sampled and not representative of the countries that they were selected from. The main population was contraceptive users, and then for the study itself, the main design was cross-sectional, repeated study. So they have about 3 rounds of household surveys. How did we estimate the direct cost? In this case, the financial cost. In costing, one of the most important things is to ask whose cost are we interested in? And in this particular analysis, we were interested in the cost of the consumer. So every cost to the health system, to the government, are excluded in this analysis. So all fees and service charges paid by the user were accounted for, and then cost of transportation to access the contraceptive was also accounted for as direct cost. And this is how we did the analysis. So contraceptive cost was estimated as the cost per last purchase times the number of visits. And the interesting thing here is that we made assumption that every visit means purchase of the same product. And this assumption was necessary because the main study couldn't record every single product that was purchased for the various visits that consumers made. But we tested the assumption, and this was tested by asking if all methods cost the same, will consumers change the current family planning method? And majority of them said yes. But in reality, products costs are not the same, prices are not the same, which means that they won't change it. In terms of the transportation cost, it was simply the cost per last travel times the number of visits. And here the assumption was also that same means of transport was used per visit. Indirect cost, we're interested in the productivity losses of consumers. So if somebody was accessing contraceptive, the person might have left his work, has traveled a long distance and all that. So we're interested in productivity losses. And this was estimated using the number of visits and then the time per round trip made. To monetize this, we use the minimum wage rate in each country, and that is provided here. In terms of economic cost, that's the summation of the financial and then the productivity losses. It was estimated by adding these two. But to test the robustness of the results, one-way sensitivity analysis was also performed. I must also mention that this study time horizon was 12 months, and we used the 2021 US dollar prevailing rate for each of these countries. For affordability, the responses to opinion on amount paid out of pocket were 3: too low, just right, and too high. But for the purposes of the analysis, we dichotomized this, recategorizing too low and just right as affordable, and then too high as unaffordable. This is what the analysis produced. So in terms of the direct cost, you see to the last 3 columns to your right, you see Kenya, average cost, Kenya, Nigeria, Uganda. And there are two main cost items here under the direct cost. Contraceptive cost was 6.86 US dollars in Kenya. In Nigeria, it was 6.95. In Uganda, it was about $6. For transportation cost, it was 1.42 in Kenya, 50 cents in Nigeria, and 1.41 in Uganda. So the total direct cost on average in Kenya was 8.27, 7.45 in Nigeria, and 7.43 in Uganda. And these are the out-of-pocket payments that consumers made for the 12 months. Indirect cost, which was mainly travel time cost, was 1.19 in Kenya, 1.1 in Nigeria, and 0.45 in Uganda. So overall, the total economic cost was highest in Kenya, which was 9.46. In Nigeria, it was $8.55, and in Uganda, it was 7.89. Now, let's see the distribution of the cost. In Kenya, about 73% of the total economic cost was as a result of contraceptive cost, and then 15% was transportation cost, and just 12.6% was travel time cost. In Nigeria, over 80% of the cost was attributed to contraceptive cost, and then just 6% was transport cost. In Uganda, about 3/4 of the cost was as a result of contraceptives, and then transportation cost was about 18%. The least was travel time cost, which was less than 6%. So this is the distribution of the direct and indirect costs here. And you realize that in Uganda, for example, 94% of the cost was direct. That's the out-of-pocket payment that they made. But in Kenya and Nigeria, they are quite identical. We tried to extrapolate these results to the national level, and we simply used the modern contraceptive prevalence rate, the population of females within the ages of 15 and 49 years, and then the average cost per user of modern contraceptive. And here, it's a simple multiplication of the total number using modern contraceptive by the average cost per modern contraceptive user. So the annual cost of modern contraceptive product or service in Kenya amounted to 64.3 million. In Nigeria, it was about 82 million. And then in Uganda, about 22 million. And pay attention to the prevalence of modern contraceptive, because that is something that is really affecting the national projections here. In Kenya, the average number of visits per user was 2.35. In Nigeria, which was the highest, was 2.78. And in Uganda, it was 2.48. Now, this is the more interesting part. When it comes to the perception of affordability in terms of the contraceptive products and services, in Kenya, 3 out of 4 think that contraceptive products are affordable. In Nigeria, over 4 out of 5 think that it's affordable. But in Uganda, less than 2 out of 3 think that contraceptive products and services are affordable. Well, the steady economic cost and all that are not common, as I already mentioned. So there's one study in South Africa which estimates that the cost per user of modern contraceptive is $7 per year, and this is similar to what we found. We also found that the cost of contraceptive products and services are the main drivers of economic cost, and this is supported by the Adding It Up study. If you've read that report, you'll find this, and also the study in South Africa. Yes, in Nigeria, 4 in 5, in Kenya, 3 in 4, and in Uganda, 2 in 3 think that the amount they pay for contraceptive is affordable. And this is very important when it comes to policy. It's relevant for government to consider this because generally it looks affordable for a large part of the population, which means that the other determinants of contraceptive uptake and access should be strengthened, and this may include efficient supply chain. This study is not without limitation. The economic cost may be underestimated because the waiting time was excluded in the cost analysis. So the time that people spend at the hospital waiting to be attended to was not measured, so it could contribute to underestimation. And then you have to interpret this with some caution because it's the selected study sites are not representative of the countries. Sorry. In conclusion, this study presents relevant cost information that may guide policy decisions in these 3 countries, and maybe even for countries of similar settings. So that's the contribution of this study. And then the cost variations in these countries is also relevant for other decisions. And maybe for the private sector, there's an indication from this study that there's huge markets in these regions for contraceptives. Based on the findings, we recommend that governments should consider free access to modern contraceptive for those who are unable to afford it. Because, I mean, if you look at Nigeria, Kenya, and Uganda, there were people who could not afford it. So if there can be interventions that are directed to those populations, then that can facilitate universal coverage for family planning. And finally, we recommend that in the future, research should be directed at looking at the analysis from the perspective of the health system, or even a wider one, which is recommended, the societal perspective. So we know from governments, combine it with health system, and then the consumer's perspective. Thank you very much.
Thank you, Richard. You finished just in time. I was about to tell you that your time is over. You didn't give me that opportunity, so thank you. Well, it's very difficult to keep quiet. There's such interesting experiences and findings, and I really wanted to say something about some of the experiences. They're really, really important. But in the interest of time, I'll request the 3rd speaker, Ulla, to come and take the stage. Ulla is a lifelong advocate for human rights, in particular the rights of women and girls. She has worked and lived for more than 25 years in sub-Saharan Africa, and she can actually see the progress that has been made over the years. Ulla, I used to think you were younger than 25 years.
Well, clearly
She
not.
believes that access to sexual and reproductive health services, including access to family planning, is central to women's empowerment and is in reaching the Sustainable Development Goals. Ulla is the UNFPA representative for Nigeria, and now I'll request her to make the presentation. Ulla, the floor is yours. Thank you.
Thank you very much. And no, I'm a lot more than 25. I think I have 3 grandchildren. I think that will say it all, right? So anyway, good afternoon, everybody, and thank you for being here. And I think it's very appropriate that we are following from Nigeria after just looking at Nigeria data. So what I'll do is I'll maybe provide some context. For those of you who doesn't know Nigeria, Nigeria is a giant in Africa. It currently is estimated to have 214 million people. The population growth rate is 3.2% annually, which means that by 2050, it will be the 3rd most populous country in the world. It has a total fertility rate that stands at 5.3, goes up to 8.1 in some of the states and down to 3.6 in others, so it's very high. It also has an unmet need for family planning that is standing at 19%, and modern CPR is 12%. So it is in this context, of course, we are figuring out how we can move the needle on the CPR in Nigeria, and in a country that big, where numbers does matter. So when you do want to move a country of 214, just staying at the current modern CPR level is actually an achievement, because there's so many new users coming every year. So we are really trying to figure out how we can accelerate it. And with Nigeria being a lower middle income country, funding is really challenging. So I'm going to take us down to earth and be really practical, because we have to be practical. And we have to use the knowledge that we have at hand when we do our advocacy work. One of the findings, I'll repeat this later on, is also we don't always have to reinvent the wheel. Sometimes it's there and it's actually working. We just don't see it and we don't use it because we are innovating so much that we forget what we have that uses. And I'm not saying don't innovate. I'm just saying don't forget what we have in our suitcase. So let me see if I can make this work. So I'm so old that I like paper versions, okay? That's the age thing. Let me see. First of all, just a little bit of background. I just gave you some Nigeria background, but also to say that the basket fund commodities is a joint basket fund in Nigeria, and it was funded back in 2011, so it's existed about 11, 12 years by now. And totally, the basket fund has mobilized about $163 million. And that has been predominantly UNFPA, government, FCDO, and then some other smaller donors that has put into that. The funding gap has continued to widen because of the population growth also. The need continues to rise. And also because of Nigeria's perceived economy. The perception is that Nigeria, being an oil state, has access to money. But there's something about fiscal accountability that also needs to be factored into this that I'm not going to get into today. So as you can see from my slide up here, in 21, the funding gap was 12 million, but in 2022, it is almost 26 million. That is how fast it rises. And of course, that also had to do with some of the global leaders, contributors to funding, withdraw during the same time period, and that had a huge impact. On top of that, the COVID-19 pandemic and this associated global economic downturn, which really impacted Nigeria because oil prices were hard hit, also had an impact on the ability to continue to fundraise. And of course, when Nigeria, who has committed to 2030 and have a national blueprint, Nigeria has actually committed to a CPR of 27% in 2024. That is just around the corner, and it's a doubling of CPR, more than a doubling. So in that context, of course, domestic resource mobilization is critical. And the Nigeria Federal Ministry of Health, supported by UNFPA, then decided to actually have a consultative meeting with the donors. And the main purpose was not to ask for money. The main purpose, and that was a deliberate choice of words also in the work that we did, was really to inform donors about the situation, to inform them about the possible consequences, and then to share the family planning landscape and information about the importance of family planning. Because this is where we also sometimes forget that everyone in this room, our community, we know why it's important. But a lot of our donors who sits in countries, they don't live and breathe family planning, and therefore sometimes we need to remind them. So we did remind them why SDGs is key to unlocking the SDGs, and we used existing resources to that. So there's a lot of knowledge out there from everyone who is here at ICFP, and we decided to draw on that. We then also took, of course, them through what is the funding landscape, as I just shared with you. And of course, also took the opportunity to renew our agreement with the government in order to make sure that we could continue to leverage on UNFPA's ability to procure. We also shared, and I'm going to show that to you later because the impact was quite astonishing, but we also then talked about the mitigation measures that we needed to be better at and fast track. And of course, that's about state contributions. There's 36 states in Nigeria, and they are very, very different. It's almost like having 36 different countries. And then we, of course, also had to say, what does universal health care mean? And for everyone here, we all know there's no universal health care if there's no family planning in there. But that's not a no-brainer for everybody. So we really had to do a lot of advocacy to make sure that they also understood why we need to advocate for this, especially with a maternal mortality rate that is as high as 1,932 in the northwest of the country, even though national average is 514. Of course, we also talked about health insurance and the importance of ensuring that the vast rural community, the ones who cannot afford out-of-pocket things, is actually covered and have access to free contraceptives. So we know the mitigations, but it's about financing them. So we started also the financing conversation. But one of the things that is, just to give you an idea, and visuals always help, that is how much the funding gap has widened in a very short time span. In a time span also where the global economic situation has had a global recession. So that has made it very, very difficult. So we shared with them, and that's about using the knowledge we have, and this was really something that was an eye-opener for the donors. So using the Impact 2 model, we actually shared with them what is the impact of this. If we do not manage to get the funding we need, the one that really was eye-opening for most of them was 7,535 maternal deaths. That is 1 woman per hour who will die from a preventable cause. And there was a silence in the room when that came out. Again, we are talking to people who doesn't live and breathe family planning. So as you can see, we put this slide up there. That was an eye-opener because they don't think about it. Not that they don't want to, but it's just not part of their everyday life. We then also drew, of course, the data from, we have in UNFPA a basket fund tracker on FP procurement. Now the tracker includes also funding requirements, the amount that has been pledged by different actors. It is about when we have received money, it's about what has received, what is outstanding, and it takes everything in from 2011 to 2021. And then we triangulated all the data and used it, as I said, also into the Impact 2 model, so we could use it to analyze the existing data we had in the country. And we then used a lot of tables and charts, and I don't have time now, but if you don't know this link that is on here, that is a little video that is 5 minutes long. And it tells a compelling story to outsiders on why family planning is key to unlocking the SDGs. It's made for Knowledge for Health, funded by USAID. I highly recommend it because people who doesn't live and breathe family planning, they understand this little video. And we put it on the screen in the room and thanked, of course, the ones who've developed it for. It's out there, it's a free resource. YouTube it and you'll find it. So the key findings that we then had, or the key results, is that when donors are informed, I mean, they were clearly better informed after this. That was a key result. All of a sudden, they knew what we were talking about. And they recognized how important family planning is, some of them for the first time. It was also a great opportunity to ensure the advocacy to the government of Nigeria and committing them to an MOU, so they are now contributing $4 million over 5 years to the basket of their own revenue. And we also had the opportunity to get between the financing partners, the donor partners, establishing a coalition where we have actually improved our coordination. We've done mapping about who does what where. We are really working, duplication has declined, and the efficiency, the way that we stretch each dollar, has increased. And as we continue to unpack this, we expect it to continue to increase. And of course, knowledge and focus on the goal to end unmet need for family planning and end preventable maternal deaths, because that is the ultimate things that we are doing. And we have committed to women and girls in Nigeria and all over the world that we will do exactly that by 2030. So what was immediate, and this was interesting, Canada has never funded family planning in Nigeria before. But literally within 24 hours, we had a call from the Canadians who had shared all of this with their HQ in Ottawa. And they very fastly gave us 2 million, and it turned it around in a month and said, this is what we have this year. And maybe also a learning, this was done in the end of the year. Continue all until the end of the year, because there's a lot of unspent money by the end of the year. And this was unspent money, and they decided overnight that that had to go to family planning. And then again, what we have done is we always, with our donors now in Nigeria, we will go back and say, this is how many lives you're going to save. This is how many deaths you're going to avert. And it makes a difference. And the evidence is there, the tool is there. I'm sure you all know Impact 2. So we don't have to reinvent it. Yeah? I'm almost done. Good. So the lessons learned is, and I've said this a few times, information and knowledge sharing is critical. Sometimes it's not the money talk that's important, sometimes it's the substance talk. Substance and evidence makes a huge difference. And the engagement of partners makes a difference. Ask them, how do you think we can solve this? What do we need over and beyond money? What else can we do? Do you have other programs that we can piggyback on for awareness rising? Because they like efficiencies. They want to stretch their investments. There's so many opportunities and untapped opportunities, I think, in there. And then, of course, the role of the government in coordinating and making sure, again, that we bring evidence to the table. And we really don't always need to reinvent the wheel. Because we know. We just need maybe to learn how to talk about it more relaxed and more freely. A few last points. This is really a unique collaboration for family planning partners in Nigeria. Everyone is around the table. And we're going to really continue to keep that focus. It is formalized now. UNFPA has the secretariat. We're not charging for the secretariat. It's part of what we do to end unmet need for family planning. So it's there, it's available. It's an easy model. And here's the beauty of it. It didn't cost us any money. It cost us the rent of a hall. Yeah. So sometimes we don't have to do big, expensive events and all of this. We can take it to the States. And we're replicating that now state by state in order to mobilize domestic resources. And we now have 6 more states contributing to the national commodity basket. And then it has strengthened accountability and coordination. Because when we all pay into the same way and use last mile distribution to actually also distribute the commodities, everyone, every donor, every partner can see where does the commodities go and how do they go, what is the uptake, what difference does it make? And that's the Family Planning Coalition. So for us in Nigeria, for UNFPA in Nigeria, and in collaboration with the government, the minister was also here for ICFP because they are committed to making a change. It is difficult times, it's a conflict-ridden country. But what they also understand and what they share is UNFPA's vision, our goal, to end preventable maternal death, to end unmet need for family planning, and to make sure that every pregnancy is wanted, that every childbirth is safe, and that every young person's potential is fulfilled. And we have to take that to heart. Because if we don't, in this world of 8 billion, we're going to leave someone behind if we don't get it right. And we will not leave them behind. Thank you.
Thank you very much, Ulla. I seem to be in the right session because I don't have to remind people about time and although I'm trying to be so friendly, I don't know why people look at me and say, oh, I'm about to finish my session. I try to be friendly, not very scary. Okay, thank you very much. And you know, if I need a star campaigner, I should appoint you for family planning. It was really, it was a very good demonstration of the social costs of financing, funding, and the power of advocacy to influence policy. Thank you very much. Our next speaker, the final, is Sunita Sharma. Sunita is currently the Vice President of Health Practice for Palladium and is also the Project Director for the US Propel project. She's a health economist with more than 20 years of experience. You know, I don't like to mention years of experience because people appear younger otherwise. Okay. And has a lot of work on health policy, financing, governance. She served as the director of US-funded Health Policy Plus and Health Policy projects during 2013 to 2022. She has also served as the managing director of Futures Group in India. There's so many other recommendations, accreditations to her that it's difficult to go on and on. But, well, we have Sunita Sharma here, and she will be talking to you and sharing her wide experience. Thank you very much. And you have 15 minutes.
Yes, thank you very much for such a nice introduction. I'm presenting on behalf of my colleague, Bryant Lee. So he has done the work, I'm just presenting here. So this is this work we did under Health Policy Plus project, because we all are talking about mobilizing resources for family planning, and we talk about domestic resources, but at the same time, we need to think about not necessarily always it's about governments mobilizing resources, but what private sector can do. So this is about how we can mobilize private capital for family planning and more broadly primary health care. So that's what we looked at. Yes, I can move it. So let's look at the context. So we all talk about and we all know that health sector, if you look at development assistance, it's stagnant or it's declining. At the same time, if you look at it specifically for family planning, we have a gap, funding gap of $2.5 billion. And we know family planning is cost effective. It's an excellent investment. We talk about it saves lives, it's important for economic growth, it's important for poverty alleviation, it can help you achieve SDGs. And then at the same time, we know there are about $11 billion of blended financing deals annually. They happen. And they are in different sectors like energy, financial sector, only 3 to 5% in health sector. So there's definitely, we can think about how we can use that for family planning and primary health care. So what is blended finance? So the strategic use of public and philanthropic resources to overcome barriers to mobilizing and investing private capital in lower middle income countries to achieve development outcomes. So you see that it's about de-risking. So one of the things are removing barriers we are talking about so that we can mobilize private capital. And also very important aspect is development outcomes we are trying to achieve. So what are some of the potential structures? It can be concessional capital. And when we talk about concessional capital, it's a catalytic investment capital that is risk tolerant and flexible in ways that is different from any other investment. It's designed to de-risk early stage, small scale investments, which can later be scaled up and can attract investors. Then we also have guarantee, which is a financial backstop offered by a lending institution in which the guarantor will pay in case borrower cannot pay. And then there can be technical assistance funds, or there can be design stage grants. So what we did was we conducted interviews with experts. We met with investors, global health experts and development finance experts, impact investors, and really to understand what are some of the financing instruments, what are some of the models available, what kind of opportunities they're looking for investment. So if we look at what are some of the health financing challenges and what are some of the opportunity areas. So as we know, investors are looking for innovations. They're looking for technological solutions, disruptions. They're looking for where there's return on investment, where they can achieve outcomes. So those are some of the things they have in mind. And then we know there are a lot of venture capitalists. They are looking for these kinds of solutions so that they can achieve those outcomes as well as they have return on investment. So if we think about primary healthcare financing challenges, one is about distribution, point of sale. So if we can expand access to family planning services through non-traditional health sector distribution locations, such as drug shops and pharmacies, that can make a big change, and that may be a good opportunity to think about. Then market introduction, where we are introducing a new product which can create new market opportunities. Or it can be new direct-to-consumer technologies, like innovation of telemedicine offering and direct-to-consumer deliveries. It can be healthcare value chain, which is improving linkages between private market players in each step of the product creation and supply processes. So really, these are just some of the examples we can think about. Then what are some of the blended finance opportunities, as we mentioned, and we look at some of the enterprises or some of the companies already doing that, and then how we can really think about different financing opportunities for that. So for example, using e-learning to create access to training for healthcare workers while reducing costs and addressing the shortage of human resources for health. And we know enterprises are already doing it. Many of these opportunities already venture capitalists or they already attracted investors. And in case they have not attracted, we can also always experiment with. Then telemedicine increases usage of family planning services through e-prescribing, remote consultation, and remote adherence counseling while reducing opportunity costs to the client. So it can be attractive. Then remote education, like improves cost effectiveness of community demand generation, interventions that have proven to increase the use of modern contraceptives in lower and middle income countries. The other examples or opportunities, and especially these are very important when they are digital solutions or use of technology. So direct to consumer delivery, like products are through e-commerce platforms that we saw example, Kasha, there was another session they were discussing, which is really important, and especially youth and our young population, they're looking for those kinds of solutions. The new point-to-sale outlets, like really your more convenient local pharmacies and drugstores have methods available, or distribution which improves business-to-business linkages of firms and entrepreneurs in the health product supply chain, or bundled women's health products, like bundled products are available. So where we are looking for innovations, we are looking at use of technology, and it can really make a big difference and expedite or accelerate the achievement of outcomes. So although it's then we also know that in other sectors, as we mentioned, that energy and financial sector, there's a lot happening in terms of investment. There are also a number of different funding mechanisms or blended financing happening in education and social sectors. And there are also some examples of specific health funds. So we also thought about, like, why don't we also look at there already investment fund available, which we can use for family planning or primary health care. So one of the examples of funds is, so I'll share just one example and mention about other one. So which is HEAL Fund, and this is Bamboo Capital Partners, they're implementing it, and we have joint Palladium, I'm with Palladium, we have joint venture with Bamboo Capital Partners, and also they have partnership with Stop TB Partnership. So this is really overall, their goal to mobilize about 75 million total for this service. And in this 60 million will be private capital and 15 million will be donor funds. And in this, they're looking at for 20% first loss liability. Like as you mentioned, initially for de-risking, or donors are putting money initially and then they attract investors and mobilize private capital. So they're thinking about 50 deals and ranging from 250K to 5 million. So on average, it's about $1.5 million. They're looking at 15% internal rate of return for senior investors. Time frame is 10 years. And they are working in Africa, South and Southeast Asia, and Latin America. And what their investment strategy is, it's more of a health tech or M-health solutions for diseases, like including TB, primary health care. And in this case, they're also looking at social impact matrices. So it's not just about technology solutions, but it's really specifically looking at achieving health outcomes. So they are looking number of patients accessing care or consumer satisfaction or quality of care. So they have those kinds of indicators to finally achieve the results they are trying to achieve and be paid fully by the investor. And they charge about 2.5% management fee and 20% carried interest. So, and then there's another fund, which is Finca Venture Digital Global Health Fund, which is about same as, like it's $50 million fund. And in this, about 3 million in donor funds they're looking at, and other will be as catalytic investment, and remaining will be private capital they are planning to mobilize, and the structure is same as HEAL fund. So what are some of the pros and cons of considering or using one of the existing investment or health fund? In this, one of the things like more value for money because it's already existed, because when you start a new financing tool and you're mobilizing capital, you're putting together the structure, the transaction costs. Like we had development impact bond that took a lot of time really analyzing, looking at the situation, putting together the entire, like how it's going to work, who are the different players and all those aspects. So if it's already existed, that's really helpful. Then also this portfolio of investments naturally diversifies risk because there are different risks in different types of mechanisms in that. And also sometimes what happens, then maybe one of them will be high, they had high investment potential, it can be very successful. Others may not be that much, but then overall it's successful. So which is helpful. And donor funds may not be required as a permanent contribution. It's more they're looking for initially for catalytic funding. And also this is an opportunity to leverage expertise of investment professionals because they're already working on it and we can engage them. But there are also some cons, like donors may be looking for 3 to 5 years and this can be longer duration, so that may not work. Also, portfolio pipeline development may be challenging and time consuming, and sometimes fundraising can take time depending on the type of opportunity you are looking at. And also then donors has less influence over the investment picks because this is already fund there and they're looking at specific opportunities, and fund investment focus may only be tangential links to source of funding, as well as fund managers and investment officers may not have deep technical healthcare specific expertise. So all those issues are there, but still I think overall the way things are going in different sectors, like Palladium, we are implementing catalyzed projects, about $250 million project, where we are working social sectors, so education and health and different sectors. So that is really not only thinking about a specific financing instrument or pay for performance, but also creating an enabling environment for blended financing, because you need to make sure that the right kind of rules, regulations, policies, and conditions exist, as well as working with private sector, making sure that their processes are efficient, things can function, payment, mechanisms are in place, all those aspects. So enabling environment is also a very important aspect of it. Thank you very much.
Thanks again, making my task so easy this time. I didn't have to call anyone and call attention for the time. Well, it's been a very interesting session on financing strategy for family planning. Beatrice, the first speaker, gave us a lot of ideas and experiences. Richmond was talking about the money saved and the whose costs are we interested in. Ola was, as I said earlier, the power of advocacy to make a difference. And Sunita talked about the financing opportunities for family planning and the new funding opportunities available. What it tells us is money actually is not a problem. If you are interested and if you can get results, there are donors and there are investment opportunities always available. The only thing that is lacking is passion, the desire to work. I open the session for any questions. Yes, please. You identify yourself, your name, the place, the country where you're coming from, and the question who is it you are addressing to. She needs a mic.
Thank you, moderator. My name is Wambo Ikongo from Kenya. I want to thank everybody for the great presentations. My question goes to the presenter from the University of Ghana. I noticed on the cost of direct cost of contraceptive commodities that Uganda has really got a great difference, like almost $1 down than Nigeria and Kenya. And I was wondering what you'd attribute that to, how they have brought down their costs, and maybe also what lessons Kenya can learn from there in terms of reducing our costs as we go towards implementing our investment case for ending unmet need for family planning. Also, 100% domestic financing, as my colleague Beatrice presented, and also to achieve our FP 2030 commitments. Thank you.
Do you want to answer the question now? We'll take questions one by one. Okay, please.
Thank you very much for the question. In terms of the difference, the cost difference, there's no direct explanation, but we can attribute it to maybe the source of these products. So for example, in some countries, the outlets were private sector and pharmacies and all that. So depending on which dominates the source of procurement, so for example, if many of these consumers get their products from a private sector, whether it's a private health facility or a pharmacy, those have high markups for profit purposes, so they are likely to be higher. Yeah, I mean, these details were not analyzed, but my colleagues have done other works that shows the distribution of the source of these contraceptives. So I'm thinking that the very outlets where consumers get their products and services can contribute to this difference. Thank you.
Any other questions? Yes, please.
Okay, my name is Julius Korir from Kenya. I'm very excited with the presentations on those on advocacy and their effect on increasing resources for FP. Now, I have one question for the costing component. There are two things. I've seen you have included the cost of contraceptive. In Kenya, about 70% of the clients or users don't pay for the contraceptive because you are looking from the perspective of the user. That user is able to access for free. So was the cost of that contraceptive weighted, or you've assumed that everybody is buying, but not that majority are not buying? So it's something maybe to consider. Then in terms of the productivity loss, minimum wage will really understate the cost. And for example, in our case, the data on wages are available from our economic survey and statistical abstracts. So you can be able really to get the wages across informal sector, formal sector, which you can maybe make use of an average if you don't have information on the kind of occupations of those. So using minimum wage really understates. Thank you.
You seem to be too much in demand.
Thank you very much. I like the question and then the contribution. Thank you. Yeah, I understand the fact that some of the population, I mean, the 70% gets it almost for free, and probably that is evidence in the modern contraceptive prevalence, which is almost 70%. That notwithstanding, there are still a part of the population that buy out of pocket. So in this analysis, it was actually restricted to out-of-pocket payments. Yeah. And then concerning the second part of using the minimum wage, which underestimates, perfectly understood. I will consider your suggestion in that. But again, there is difficulty in using that estimation because you also want to be fair in the distribution of income. For example, if somebody works in the banking sector, the person's income may be different. But for what proportion are you going to consider? These are the reasons why we do sensitivity analysis, so that you know when that particular parameter changes, what happens. Thank you very much.
Anyone else before we call it a day? Yes, please.
Thank you very much. So this is not a question. I wanted to just appreciate the UNFPA rep for the presentation. I think it aligns with us on the field who are also struggling to get family planning and issues of SRH accepted by stakeholders. And I just wanted to share an example or some brief story from Ghana. So we, after several years of advocacy for family planning and SRH, got to a point last year where one of the religious leaders spoke to us about the reason why they are against people taking up those services. And he cited that for them, family planning means limiting birth. And that is what has been registered in their heads, that you want to limit birth, but they are not seeing the perspective of spacing children in that concept of family planning. So they are so much against it because the perception is still that people want to limit the population and numbers, and so they don't want people to give birth. So I'm just citing this to also link to our new approach as an organization in Ghana, where we now see opposing views as people who need support to understand rather than enemies of our work. And I think that is the same thing that they are doing in Nigeria. Just to say that a lot of the time, these people need us to help them to understand. It is not because they don't want the good of the country, but it's because they do not get the perspective we are privileged of. So I just also want to say that we may have to push on more of this engagement, and hopefully we can get the whole world to understand our view on family planning and SRH. Thank you very much, ma'am.
So thank you very much. I think you're raising an important point, and this is maybe not the time to flag this, but that's my point about being better to inform and share your knowledge. Make it something that every person understands. Because I think we have a tendency, I'm not old in UNFPA, I'm very old in reproductive health, but not in UNFPA. But we do have a tendency in this sector, and I say this with a lot of love, but we make it into something very scientific sometimes. And actually, family planning is not rocket science. And I think we need to be better at fleshing it out. So this example of changing the words, for instance, to child spacing, I think many of us do that in our everyday life. But what it means, because we have the same, how many of you have had pushback from religious leaders on family planning? I know I have every single day, yeah? And this issue about explaining that actually this is, spell it out. Reproductive age is 15 to 49. Realistically, we would like you to wait till you're 18. And let's just say even you then have children up till you're 38. That's 20 years. So instead of having to bury every other child because it doesn't survive, and having your wife getting bad health and spending a lot of money on health cost, you have 20 years to get to your 10 children with good spacing. Yeah? And that people understand. So you don't need to have one every year to get 10. You can, see, this is how many years you can have babies. Explain it, make it real. Because I think that is what we need to be better at. And this is very personal, I spent my entire life working on this, and I think that's where we can really improve. Make it real, because when we make it real, we make it matter. And we take it into people's families. And I think so, thank you very much for Ghana for sharing that example.
Yes. I don't get the opportunity to speak.
Hi, my name is Marta Levitt. I'm the Chief of Party of the USAID Integrated Health Program in Nigeria. And we work in 3 states in the north, and then we also work in Ebony and FCT. I would like to just say that we were so surprised. We work in primary healthcare centers all over Bauchi, Kebbi, and Sokoto. We found the demand was 2 to 3 times the supply. We trained health workers, community health workers. They know how to provide LARC. They can provide any family planning. They do counseling. But the commodities keep running out. So I think when we talk about financing, it's really important that we make sure that we are quantifying correctly, because we're not in a state where the demand has already been solidified. It's a growing demand. You can't use historical consumption anymore. And people have been doing that. You've got to look at the demand. We have waiting lists of women who are trying to get the method of their choice. So I think we really have to figure out the financing for family planning. We have to have the right numbers. It may, the government, like you said, $4 million over 5 years is a drop in the bucket. And we really need to figure this out, whether it's at the federal level, the state level, so I don't even know what the solution is. All I know is I have all these women who are ready and cannot get their contraceptives.
So thank you. I think we all experienced that. And so just, as I said, everyone is around the table in the coalition. And so I have Paul and Gertrude working with us, mapping out what everyone is doing, right? But what I just want to say is it's not 4 million over 5 years, it's 4 million annually over 5 years. So it's 20 million. It's still not a lot, but it's more than 4 million over 5 years. Okay.
Richmond, you have 25 seconds.
Yeah, so I wanted to follow up on what she was talking about. So isn't it's also an issue of supply chain? Is it just a matter of financing? Because it is expected that the supply will come from government. What's the role of the private sector? How are these consumers assessing it, maybe from private outlets, I mean, in that space?
Okay, friends, we are running out of time. Just a final word. You see, there's no denying, and we are all family planning experts and family planning champions here. There's no denying that family planning is a fundamental right. No one ever questions a human being's right to health or right to life. A woman is allowed to go to a clinic for medicines. The same woman is not allowed to go to that same clinic for preventing or for her own health. We have to think about family planning as a fundamental right that is for all. This is one. We don't have this session on advocacy, otherwise there would have been many other points. The other point that is important is when we talk about maternal mortality, every country, every person talks about maternal mortality. Let us remember, a woman who is not pregnant cannot die of maternal mortality. So if you have to reduce maternal mortality, invest in family planning. A non-pregnant woman cannot die of maternal mortality, as simple as that. And finally, we do a lot of work on investment cases, return on investments, how much of money is for example, how much of money I have to pay out of pocket to visit that center today for a supply of 3 months. Let us also try to find out how much of money I have saved by this visit today. These 3 months cycle of pills have saved me 1 pregnancy and how much of money for the next 4 or 5 years. What you are doing is appealing to the policy. Now let us appeal to the common people. Thank you very much. Very interesting and very enriching session indeed. I'm thankful to everyone, my expert speakers, as well as the audience. I didn't expect such a big audience today. Thank you.